Okay, thank you. So I just wanted to reiterate what Lucas was saying about the importance of evaluating the new technology and making sure that it's safe and kind of optimizing this new technology. You know, we've done a lot of that work when we first started using this technology, and I think the evaluation and feedback that we've been providing to the company has been ongoing. And you know, just earlier this morning, we had a meeting with other users of this technology, sharing our successes and our challenges. So hopefully, with this presentation, I can kind of highlight the effort that has been put in to kind of evaluate the technology, the planning, especially, and ensuring that we're delivering, kind of generating high quality plans. Okay, so disclosures. Personally, I don't have anything to disclose beyond what Lucas had already disclosed earlier regarding Stanford's collaboration with RefleXIon. But in terms of what I'll go through today, you know, Dr. Wittem has already kind of gone through kind of the machine overview, kind of design. I'll touch upon that because I think it's important to understand what it is capable of, the system's capable of, which will kind of inform our planning approach as well. I'll discuss the two different modes on the system. There's an IGRT mode, IMRT mode, and then the BgRT mode. And once again, I'll provide a BgRT case example so that we can kind of see the workflow and the additional resources required for this new technology. I mean, in a nutshell, if you're familiar with the thermotherapy system, then this system is very much designed like a thermotherapy. The ring-based gantry, it's got a single energy. The dose rate is quite high. It's 1,000 centigrade, 1,000 MU per minute. It's got a bore size that's similar to the CT scanner that we have for planning simulation, which makes it convenient for kind of patient setup. And as well, I just want to emphasize there's no gating on this machine in this current release anyway, which kind of limits a lot of the type of patients that we can treat on here. But that's something that I'll kind of touch upon a bit later. This is just a couple of schematics of the kind of machine, which kind of shows how the KVCT, the PET detectors are aligned within the system. Nothing that we need to go into too much detail about, but the delivery itself, it's not like the kind of normal traditional LINAC, which kind of just rotates around the patient in this kind of and delivers this beam in a conical fashion. The delivery itself on the system is a step and shoot type of delivery, and the couch will kind of march in towards the bore, or it'll go in or out depending on how you set it. But the treatment itself is in a stepwise fashion, so it does increase the treatment time overall. Now, I will kind of highlight the IGRT, the IMRT mode, which is kind of similar to any other kind of modern day LINAC. Able to do, the system's able to do very nice IMRT delivery. And the workflow itself isn't different from what we are doing on the LINAC. So patients that get simulated in the clinic can either be treated on a LINAC, or the patient can be treated on the RefleXIon system without any kind of additional changes beyond a new plan being made that's appropriate for the system. So the patient will just undergo CT simulation, volumes will get contoured, and then the plan will be set up inside the system, kind of with input from the physician to define the prescription, similar to any other TPS, treatment planning system. Optimization, objectives and constraints are done, and you can evaluate the plan within the system, which will also undergo QA, and then the patient will be set up on the machine with kind of pre-treatment imaging, localization before treatment delivery. So that's standard workflow. We do have inclusion and exclusion criteria for the system, and that's mainly something that is the list is ongoing in terms of what makes an inclusion criteria and what makes an exclusion criteria, and it's a lot of it's pretty much based on our experience and the dosimetrist experience with generating plans that are similar in quality to what we're currently generating for LINAC-based treatment. But pretty much we treat all clinical sites on the system. In the US, we are based on kind of treatment based on insurance authorization, on IMRT kind of approval. So we're limited to treating patients with kind of IMRT, SBRT type approval. The system isn't able to deliver a 3D conformal type of treatment, so it can only deliver IMRT mode. The main exclusion criteria for treating patients on the machine are for any patient that requires the motion management, like breath hold or kind of amplitude gated treatment. There are some degradation in the dose distribution for off-axis targets. The plan can be generated, but the plan quality is not as good as it can be on when compared to a LINAC-based plan. So given the option of treating a more conformal plan on the LINAC, then we kind of exclude these patients with tumors that are kind of quite off-axis. One thing that the dosimetry team have to consider when setting up this plan is the ISA center position. For LINAC-based treatments, the MLC carriages, the design of the MLCs and the gantry rotation, it's important to ensure that the ISA center kind of takes advantage of how the MLCs and the field size can be generated with this system. Because of the ring-based gantry and the firing positions can be defined, is generally generated from the system based on the inputs, the optimization inputs. Our ISA center doesn't necessarily have to be localized within the target. It can be kind of established in midline, and for kind of unilateral targets, then the system will generate an appropriate dose distribution based on kind of firing positions closer to that side. And we do have a guide that tells us kind of the optimal position of the ISA center to ensure appropriate clearance. Because it is a bore-based treatment delivery system, there is like a sweet spot for where the ISA center can be in order to ensure maximum clearance of the patient inside the bore. And we have a guide that kind of tells us what's the best position to put the ISA center and get ensure proper clearance. The optimizer itself isn't too complicated. It's actually quite user-friendly once you get used to the user interface. It is a cost-based kind of inverse optimizer. You can put in kind of time penalties to reduce the overall treatment time by kind of affecting kind of how modulated the plan becomes. The calculation grid, the 2mm calc grid, and the algorithm for the dose calculation is the collapse cone convolution type algorithm. And this is just an image that kind of shows the input for the dosimetrist. They can put in different weights, so different objectives for different contours, and the system will give us kind of the penalty that, or the kind of the cost function associated with kind of our input values. So it's not an interactive type optimizer. So we do have to try to be more kind of diligent with kind of the values that we're putting into in the optimizer. So it does take us a bit longer to generate plans because of this, but it's like I said, it's not too complicated to use, and we've been able to generate some pretty nice comparable plans, plans that are comparable to VMAT LINAC-based plans. And when we first started, went live with the system, we did do a clinical evaluation planning study to evaluate a number of different sites to see how the plan quality would compare to our institutional standard of kind of LINAC-based VMAT technique. We looked at kind of lung sites, conventional lung, head, neck, prostate, anus cancers, brain cancers, and as well as lung SBRT plans. And this diagram kind of shows the dose difference for the different sites, and if there's a gain in kind of dosimetric gain for different organs at risk with reflection type plans, then you'll see these this mean dose on the left side of this plot. And if there's a significant gain, then it's highlighted in red. And if there's when the bar is on the right side of this plot, then you'll see the gain for the kind of VMAT Eclipse LINAC-based plan. And in general, we were able to kind of see very comparable plans across kind of different sites for prostate cancer, kind of conventional lung, SBRT lung, and similarly for anus cancer, brain cancers, and head and neck cancers, we're able to show that the plan quality with reflection is similar, and if anything, it can improve kind of dosimetrically on kind of different structures in the head and neck and kind of the brain region. So we kind of were pretty happy that we were able to generate some high quality plans before going live with the system. This is an example showing a head and neck patient, the plan quality, kind of the dosimetry and the conformality. So on the left is the reflection plan, on the right is the VMAT plan. And this patient has two dose levels, 60 gray and 54 gray to kind of the nodal regions. And you can see that the heterogeneity, the conformality is good, and the heterogeneity or the homogeneity of the plan is actually quite nice as well. If anything, the reflection plan was able to generate a more homogeneous looking plan than the LINAC-based VMAT plan. And this is something that kind of working on the plan quality and improving the plan quality for reflection has been a learning experience for the entire dosimetry team. And it's something that we're kind of continually investigating and trying to improve. What I did want to highlight here is the treatment time, because it is this step and shoot type treatment. For the planning study, we did find that the treatment time was a lot longer than on VMAT compared to a VMAT-based plan. For head and neck, it's almost 1.5 times. Prostate's almost double the time. Lung SBRT is quite significantly higher. And kind of similarly for kind of other sides like the anus, it's also very high compared to VMAT-based plan. And because the treatment itself is based on the couch moving into the bore, kind of slice by slice, kind of in a kind of small increments, the treatment time is correlated with the entire length of the target. So longer target means longer treatment time, effectively. And I wanted to kind of highlight kind of this big effort from the dosimetry team to kind of in terms of evaluating and improving plan quality. We treat a lot of head and neck patients on the system, and plan homogeneity is a goal that we strive to achieve on all of our head and neck patients, like a homogeneous dose distribution. And kind of based on this planning study that we did, kind of comparing VMAT plan, manual-based VMAT plans, auto plan versus reflection plans, we always found that the Dmax, or the dose to 2% of the PTV, the in effect, the heterogeneity in the plan was always higher with reflection plans. But it was still acceptable, but compared to VMAT plans, the plan was just more homogeneous looking, and it's something that we've been working to try to improve on. And more recently, we've actually come up with a method to try to improve plan homogeneity, and we found that by splitting up the PTVs into different sections. By splitting the PTV up into different sections and putting that into the optimizer actually helps improve the overall plan homogeneity. So this is an example of a patient. This is a PTV 70 volume, quite extensive disease, and we split this up into 6 different sections, so like an upper, a lower, a left and a right, mid upper and a mid lower. And by putting that into the optimizer, we were able to generate a really nice looking plan. So on the left, an example of the same plan with a single PTV 70 volume that's put in the optimizer, which is our normal practice. And on the right is when we split that PTV up into multiple volumes and using the same objectives, same constraints, we were able to get a very nice homogeneous looking plan. So this is a sequentially treated plan. This is the second phase of the treatment, going to 27.5 gray, but this is the dose. 28.93 is the 105%, and you can see on the left it's a lot more heterogeneous compared to when we on the right hand side plan. So the DVH itself, if you compare the two, when you split up the PTV against not splitting it up, the PTV coverage itself is similar, but the homogeneity is much more improved by splitting up the PTV. And kind of preliminary analysis comparing the dose to the PTV when we split it up versus not splitting up the PTV has kind of shows some nice gains. So the PTV max, the maximum dose of the PTV drops quite a lot from, on average, 110% down to 100, just under 107%. The minimum dose increases, but the volume of the 105% just drops dramatically, which is really nice to see. And this analysis that we've done isn't just for head and neck patients, it's for rectum case, scalp case. Yeah, so it's kind of a mixed bag of patients so far. We're hoping to explore this a bit more. And then the time itself does increase, but not by a big amount. So going into the BgRT, SBRT mode, so that was just a recap on all the IMRT, RGRT side. So going to the BgRT planning itself, this is kind of similar to what Lucas kind of showed previously. The workflow itself is a bit different from traditional kind of IMRT, RGRT based planning and treatment. The simulation still occurs in a CT scanner, but there's an additional planning scan that is required on the reflection treatment plan, on the reflection treatment delivery system itself. And this is called the imaging only session, and that step in the process allows us to acquire this PET image for planning, which influences the actual optimization process itself. So there's an additional step, an additional appointment for the patient to come in and have this planning PET, and that's similar to other systems. There was a presentation on the V-Ray system whereby you need the MR from the machine itself to do the planning. So in a similar fashion, you require this BgRT-based planning requires a planning PET that is acquired on the system itself prior to optimization and planning. The volume itself that's generated for BgRT because we're using the GTV itself as a fiducial marker, any margin that is required is just based around the GTV itself. For traditional SBRT planning, for kind of motion inclusive type planning, there's an ITV that is generated that takes into account the entire range of motion, and that generally is used to inform the PTV generation. But with BgRT-based planning, because the system itself is tracking the GTV, the tumor itself with the PET emission, the PTV margin is just based on the GTV itself. The patient selection criteria for BgRT-based planning, as Lucas had already mentioned, is limited right now to lung or bone, and that's an FDA, as regulated by the FDA based on that a clinical trial, that investigation that was done. Tumor motion of less than 1 centimeter is what we are capping at right now in our institution, and there's ongoing work, a collaboration with Stanford and the RefleXIon engineering team to investigate the impact of larger motion and how that impacts on the dosimetry. There's a GTV volume restriction, and as well there's a minimum PET avidity that is required, as well as its location relative to other kind of FDG avid type structures. So the BgRT workflow, I just wanted to kind of touch upon the fact that the optimizer itself, it takes into account the planning PET image itself, so the quality of the PET image and the shape and the how the distribution of the PET itself does impact on the planning itself. And in a nutshell, the system generates a number of different fluences based on kind of these kind of limited time sample that's of the PET acquisition itself. So I just wanted to kind of show this case study. I know Lucas already kind of gone through this, our experience with the first BgRT patient. So I just wanted to kind of go through that process again. Won't spend too much time on it, but there's this patient, 58-year-old female, diagnosed with a right middle lobe tumor, had a pretty high SUV max, and the prescription 50 gray in 4 fractions. So you can see the tumor itself back in June, and then in August, kind of growing slowly. The patient is positioned head first supine, arms by the side. Normally, we would treat patients with arms up for SBRT, lung type treatments on the LINAC. Because the treatment delivery itself is quite long, it's around about 30 minutes. That's the delivery time itself, not including the PET acquisition and kind of KV CT localization. It could take up to an hour, or if not more. We didn't want the patient to have their arms up, so we have the patient's arms by the side to make it more gentle for them for treatment. There's a custom backlock cushion kind of molded around the elbows to ensure that we can reposition the elbows in the right way. The patient is scanned on our Siemens CT scanner. We acquire a 4D CT. The 4D CT is important to evaluate the motion extent of the tumor. And then a PET CT can also be acquired, diagnostic PET CT, and then a number of kind of breath hold scans are also done so that we could generate a backup plan in case BgRT treatment doesn't work out for whatever reason. The GTV volume is generated. An ITV volume is also generated, not necessarily to create the PTV margin, but it's the ITV is outlined in order to create what we call the biology tracking zone, which kind of defines the motion extent of the tumor and will also inform the field of view of the PET acquisition during treatment. And after the volumes have been generated, the patient comes back for what we call this imaging only, this imaging session. This is a planning PET session that's done on the RefleXIon system. We schedule this kind of 1 to 2 days after the initial CT simulation, and the GTVs or the PTVs are outlined, and this kind of, by knowing the full motion extent of the tumor, we can also let the system know that this is the kind of range of motion that we expect the tumor to be kind of confined within. And that helps generate this PET image that's used for planning. So the PET is acquired, and you can kind of confirm that it's still the same size, kind of still within the area. There's no new kind of PET avid areas that have popped up since the time of the initial kind of diagnostic PET. And as had been mentioned earlier as well, this is also a good opportunity for us to ensure that the PET avidity, the intensity of the signal is high enough so that the system is able to properly track and treat the patient. And there's this activity concentration, which it needs to be higher than 6. And for this case, it's much more. It's almost, kind of 4 times that. And then the normalized target signal is just comparing this signal relative to the background region, kind of around the, kind of in the immediate around the PTV itself. So once these minimum criteria have been met, then it's pretty much a go to say that this patient is BgRT kind of suitable. Planning itself, there's no additional OARs beyond our standard organs at risk that's used for planning. So the way that we normally plan our SBRT with kind of tuning structures, optimization structures, they're still the same. We import these contours into the planning system and use them to put limits on kind of our typical dose constraints. And the plan quality itself is quite comparable to conventional LINAC-based VMAT plan. So on the right is the RefleXIon BgRT plan, the prescription of 5,000 or 50 gray. On the left here is the VMAT plan. On the right here is the RefleXIon plan. This is the intermediate dose spillage, the 25 gray or 50% isodose line. You can see it's nice and relatively tight. And then the high dose region, it's nice and conformal, stays within the GTV as well. In terms of plan evaluation, Lucas had kind of mentioned this bounded DVH, which is generated by this software kind of calculating these potential dose to organs at risk based on tumor shift or kind of a signal shift or the kind of PET GTV shift of up to 5 millimeters in all 3 directions, left, right, supine, kind of and post, and as well as it also takes into account some changes in PET signal kind of intensity as well. And as has been mentioned, we're still evaluating how to properly use this in evaluating plans. But for now, for most of our cases, well, for the cases that we've treated so far, there haven't been any critical structures nearby. And one of our exclusion criteria for patients is to not have a critical structure like spinal cord or kind of brachial plexus or kind of highly sensitive organ at risk that's nearby, overlapping with the GTV. In terms of the plan quality, this is just a summary of the plan quality metric comparing the BgRT plan against the SBRT plan. For the most part, all the OAR constraints, the minimum dose, maximum doses are similar. The OAR, organs at risk, is also very similar. The biggest kind of noticeable difference is obviously the treatment time because of the step and shoot manner of treating, as well as the way that the design of the PET image acquisition, reconstruction, and fluence generation is required, the treatment time is a lot longer. The R50, or the kind of conformality of the 50% isodose line, is actually higher than what is possible for traditional SBRT plans, and that's something that, while not necessarily a roadblock to kind of choosing, whether or not this plan is safe to deliver or not, is just something that we're kind of feeding back to the RefleXIon team to inform them that there could be improvements that could be made, and this is one area that they should kind of look into and investigate. The treatment itself requires a lot of input. I mean, it's a big team commitment, team involvement. We have nuclear medicine technologists on site, and they are present to help kind of handle the radio tracer. We have radiation therapists, so 2 on treatment. We have a nurse that is kind of present in the morning. There's an on-site engineer from the RefleXIon that's always there, helping with just both BgRT and IGRT treatment. Kind of not necessarily with the treatment, but in case there's any problems, they're around to help solve or diagnose. The physician is required for on-treatment verification. Physicists are also present for verification, and dosimetry will be on standby to evaluate the plan, kind of the delivered plan post-treatment, and that's something I'll kind of touch upon in the next few slides. Because there is this half-life of FDGs, around about 109 minutes, it does kind of degrade over time. So we do try to ensure that treatment, or kind of the PET imaging acquisition begins at a certain time point after it's been injected into the patient, and it's around about 45 to 1 hour post-injection, to not only let the tracer settle into where it needs to be, but we don't want to prolong it because the signal may degrade over time. So on treatment, so once the patient is kind of localized using the KVCT, this PET image is acquired. This is on treatment for the first fraction, and you can verify that the signal is still inside the area that we're planned for, inside the GTV or PTV. And the software itself will do this evaluation based on this PET emission, or this PET reconstruction. It will evaluate to ensure that that there's no more than 5% kind of dose difference to kind of OARs around the area. And then it will once again check the activity concentration and the normalized target signal to ensure that it's able to detect the signal and appropriately kind of filter out kind of any background kind of activity as well. And if it's all green, that means it's good to go. And this is the treatment itself. The MU does vary on at each fraction, and once again, that's kind of based on the PET activity, the emission, as well as the kind of the delivery and how it picks up those PET limited kind of time sampled images to kind of deliver its fluence. We do aim to have the patient receive treatment at the same time every day, so that there's no kind of changes in the habit in terms of like if they're trying to do like any strenuous activity. So the patients are coached to go on a fast, like to be fasting the night before treatment. So the treatment's generally the night in the morning, and not to have any strenuous exercise kind of the day before as well. And this is kind of post-treatment analysis of this patient. We have 4 fractions: the mean dose and the max dose, kind of from each PET delivery, PET kind of acquisition and delivery. It's pretty similar, didn't deviate too much. And once again, the DVH, because there's a new PET that's acquired, this volumetric PET image that's acquired from the treatment, we can reconstruct the dose based on the new PET image. And by summing that all together from fraction 1 to 4, we can compare it back to the original plan. And in this case, we saw this kind of increase in mean dose to the GTV and PTV, but very similar dose to kind of no big change to dose to organs at risk. One thing that we've been, this is another case, but just wanted to kind of highlight kind of plan quality. So we are definitely evaluating the plan quality and feeding this back to the company to kind of see how they can improve things. This is an example of this patient that we generated 3 plans, and we wanted to improve the 50% or the intermediate dose, the ratio of the 50% isodose line relative to the PTV. For a lot of clinical trials, lung SBRT clinical trials, there's a requirement to have a certain ratio for a given GTV size or PTV size, and the ideal ratio is around about, for this patient target anyway, it was about 5.3 to 5.5 is the ratio that we're aiming for. It's hard to generate that with this new BgRT plan without kind of increasing kind of the effective modulation of the plan, increasing the treatment time, and as well increasing the heterogeneity. And with the same volume, the same plan, if we didn't use BgRT type treatment, but use the kind of the IGRT, SBRT type treatment on the reflection system, then you can create a nice plan with a nice intermediate dose spillage. The treatment time is also a lot less than the Dmax. Heterogeneity within the plan is kind of more what we expect to see, around 120% inside the GTV. So it is possible, just a limitation with the algorithm generating the plans right now. In terms of just a summary of our timeline at Stanford and what we've been doing with the RefleXion system, the system began at the end of 2020 for the installation and commissioning. In January, commissioning was completed, and it was until May that we treat our first IMRT IGRT patient. And then in April of this year, the kind of based on the findings from the clinical trial that Lucas had mentioned, and FDA approval, there was a big software upgrade, and we were able to treat our first BgRT patient in August. And to date, we've treated quite a lot of patients on the machine, more than 200 patients, averaging about 10 patients a day. And the patient appointments are a bit longer than the normal Linac-based appointments. They're about 30 minutes. And that's to account for kind of like the longer treatment delivery time, and as well as kind of some workflow kind of limitations in terms of record keeping and approval of patient treatment records post-treatment. So the appointments are a bit long, but the majority of patients that we're treating on our system, the head and neck patients, plan quality has been great. Image quality has been really good for localization. And then we've been treating a lot of pelvis patients, GI, gastrointestinal type cancers, the rectum, anus, esophagus. Patients that don't require gating are also on there. Thorax-based patients, so patients that don't have any gating, breath hold or amplitude gating, we also treat on the system. I've been treating quite a lot of scalp cases, SBRT, brain, abdomen, and prostate. BgRT kind of make up the tail end of our patient load. So, it's a big team that's involved with getting this system going and kind of putting patients on there. And just a shout out to everyone that have been kind of actively involved and doing, amazing work, trying to improve the quality of the plans, machine, and as well as offering patients a kind of nice opportunity to see something new. And that's it.
Thank you so much, Daniel. Excellent lecture. Awesome. So we'll open the floor for questions and discussion. I already see 2 questions in the chat. So is it necessary that we have to inject FDG for every fraction? And if we can do RT without PET, can the reflection still be tracking the moving lesion?
We do have to inject each session. It needs that radio tracer. There's been some research going on to see if we can look at some longer acting radio tracers such that you don't have to inject each time. No, it's not able to track without the radio tracer.
Yeah, so there's active research going on at Stanford with zirconium-89 panitumumab. So it's a long-living tracer. One of our research physicists, Guillaume Prats, is working on this. And so what they found is on the experiments of mice, on a mice study, they found that the PET contrast actually is valid up to 9 days. So we can potentially use it in humans, and we can treat SBRT type of fractionations of 5 fractions with it. So that would be amazing, but it's still investigation. And there's another question. How many lesions do you treat in one treatment course on reflection if you have oligomets?
So in terms of the definition of oligomets, something we don't have a clear answer for, and I think it's something we might never get a totally clear answer for, but looking at 3 to 5 mets at the upper limit. In terms of on reflection, so far we've just done for the BgRT one site, as I mentioned, doing multiple lesions in parallel is something that is theoretical capacity for the machine that we're really excited about going forward, but currently it's just one site. We have treated a patient with multiple sites using image guided multiple bone tumors.
Dr. Chappell, you are muted.
Sorry. Thank you for the answer. And I also have questions. What is more cost effective, for your opinion, MRI Linac or reflection?
Good question. To be honest, I don't totally know how much these things cost. That's kind of been above my head. So
They are similar price.
Okay, similar price.
Yeah. What would you buy for your clinic?
The MRI Linac is definitely farther along in technology, so I think that's something we're looking on that roadmap of value technologies that has randomized data to support it. And I think has a clear use case where reflection is still figuring that out. So I think if you want the safe bet, something where it's clear today there's a benefit, buy a ViewRay. If you want to take a bit of a gamble and think maybe this will be revolutionary, we're still figuring it out, then get a reflection.
Lucas, ViewRay is bankrupt, so I don't know if it's a good gamble.
Yeah,
Not sure.
Fair point, I guess. And actually, so one news that I didn't share was too that at least for us in the US, so much of what we do is just determined by billing, and they got in code through Medicare, which means that they will get to charge more for this therapy. So I don't totally understand how all these things work, but they
reflection
have
reflection for BgRT. Yeah.
Whereas ViewRay never did. But yeah, no, that's exactly right. That is enticing that ViewRay is gone bankrupt.
But
so
there's still Elekta though, right? Elekta Unity.
yeah. I mean, I think one thing that people probably don't emphasize enough is the image quality of the KVCT. I think there's potential to do adaptation with that image quality. I mean, ethos, it's still, the image quality is still kind of somewhat post-process, it's not going to be the same image quality as this KVCT. So I think that's something that we can potentially leverage in the near future.
Yeah, it's a great point. I mean, even if BgRT, even if you're not using that, it's a effective image-guided radiation therapy system. So
Just for IGRT, the image quality is so much superior. And it should be really harnessed for adaptive, but currently the company is not really investing into that aspect of RefleXion. I think they are concentrating on BgRT and developing it further, but I really feel there is a big benefit for adaptive on this platform.
I agree. Yeah, we treat more patients each day on, at least in the is going on reflection, including the image guided, than we would on URA.
Right. And Lucas, what's in your opinion the biggest benefit of RefleXion? Let's say not now, but maybe in the future, where do you see a biggest benefit?
For me, it's definitely in the multi-mat, like treating people in parallel. And if we can make that vision come to reality, that's something where you're getting in the 3 to 5 treatments. There really isn't, it is a hassle, I think, with existing technology to try to figure out how to do that safely and efficiently. So if you can figure that out, it would be a big deal.
And for you, Daniel, what's the biggest benefit?
I think KVCT, I think that's kind of overlooked. But the possibility of like PET adaptive, maybe something to think about as well. But yeah.
It's in the future. And maybe tumor-specific tracers, right? Now that can really revolutionize the treatment and improve the therapeutic ratio. Any more questions? Yeah.
Maybe on the future, we have possibility to treat on RefleXion oligometastatic disease, not only one lesion or many lesions for one treatment course. It will be also interested.
Yeah, definitely. I can imagine this can be a machine of the future because you can come and you can get diagnosed in that machine, right? And you can get treated right away because you could track the tumor. So that's possible. Yeah. Kirilo, you have a question?
Yes, thank you for a good reflection. And my question, maybe you had some cases when after 1 or 2 fraction activity of tumor had low, and how you evaluate in the next fraction. For example, in first and the second fraction, we have many contrast enhancement about FDG, but after on third, on fifth fraction, we have little bit low enhancement, and how we evaluate the target.
Yeah, it's a good question. And we've only actually in reality treated 2 patients, but then done emulated in about 9. We haven't seen that yet where it did work and then kind of changed enough. The signal does change, but the not to a high enough degree that it wasn't able to still deliver the dose. But I certainly think it's a theoretical possibility that it could happen. If that occurred, you would just deliver normal image-guided radiation without the BgRT.
And Emory did the study, so they actually did evaluation study where they acquired PET CT scans before various fractions of LANA's BRT and saw how much of the alteration and differences in activity concentration for the PET tumors throughout these fractions. And they found on average 25% differences in concentration. And that's why this 25% is added to those bands of the DVHs. So it's added to the uncertainty of that concentration. But machine evaluates before we actually treat to make sure that it's within those bands and the concentration is within the thresholds. And otherwise it would not proceed.
Okay, thank you.
Any more questions? If not, thank you so much for your attention. Then the next lecture will be the last lecture in this series. It's going to be given by Dr. Bill Lu, and it will be on Flash, looking towards the future. So see you next Wednesday. Bye. Have a nice weekend.
Thank you.
Thank you, Daniel and Lucas. Excellent work.